Let's talk. As a future family nurse practitioner, you're going to see a lot of things. Coughs, colds, high blood pressure, the usual suspects. But I guarantee you, almost every single day, someone will walk into your clinic because something hurts. Their back, their knee, their wrist. The musculoskeletal system is the framework of the human body, and when it has problems, people notice. It impacts their ability to work, to play with their kids, to just live their lives. This isn't just about memorizing bones and muscles. It's about understanding the very real, very common pain that brings patients to you for help. Your knowledge of the musculoskeletal system is not just another chapter in a textbook you have to get through. It is a fundamental pillar of primary care. Being able to quickly and accurately diagnose a musculoskeletal issue will make you an incredibly effective and trusted FNP. Is that patient's knee pain from simple overuse, or is it the first sign of a chronic autoimmune disease? Is that back pain a simple strain, or is it a red flag for something more serious? These are the questions you will face, and having a solid grasp of this material is what will allow you to answer them with confidence, providing relief and guidance to your patients. Think about the sheer variety of patients you'll serve. You'll have the young athlete with a sprained ankle, the office worker with wrist pain from typing, the older adult worried about their thinning bones, and the middle-aged person with a crippling gout attack. Each one requires a different approach, a different set of questions, and a different treatment plan. Mastering the musculoskeletal system means you are prepared for this diversity. It means you can provide care that is not just reactive, but proactive, helping people maintain their mobility and quality of life for as long as possible. This is what being a great FNP is all about. So, as we dive into this review, don't think of it as just cramming for an exam. Think of it as building your clinical toolkit. We're going to break down some of the most common and important musculoskeletal conditions you'll encounter. We'll keep it simple, focused, and practical. My goal is to give you the clear, high-yield information you need not only to pass your boards, but to walk into your first day as an FNP ready to handle whatever aches and pains come through your door. Let's get started and build that foundation, one bone and joint at a time. Ankylosing spondylitis, or AS, is a type of inflammatory arthritis that primarily affects the spine. Think of it as the immune system getting confused and attacking the joints in the vertebrae, specifically the sacroiliac joints where the spine connects to the pelvis. This chronic inflammation causes severe pain and stiffness. Over a long period, this inflammation can lead to a process called ankylosis, where new bone forms, and sections of the spine can actually fuse together in a fixed, immobile position. It typically starts in early adulthood, more often in men, and it's something you need to have on your radar when a young patient complains of persistent, inflammatory-sounding back pain. The classic symptom you'll hear about is chronic low back pain and stiffness, especially in the morning or after periods of not moving. Patients will often tell you the pain feels better with exercise or activity and worse with rest. That's a huge clue that this is inflammatory, not mechanical. The pain can wake them up in the second half of the night. Over time, this stiffness can travel up the spine, leading to a hunched forward posture. You might also see inflammation in other parts of the body, like the eyes, the heels, or even the heart and lungs in some rare, severe cases. Treatment for AS is all about managing symptoms and preventing deformity. The first line of defense is usually physical therapy and consistent exercise, which is crucial for maintaining spinal flexibility and posture. For the pain and inflammation, we start with non-steroidal anti-inflammatory drugs like naproxen or indomethacin, often at their maximum dose. If NSAIDs aren't cutting it, we move on to biologic drugs, specifically TNF inhibitors like adalimumab or infliximab. These powerful medications target the specific inflammatory pathways causing the problem and can be game changers for patients with moderate to severe disease. Here's your clinical pearl. When a young male patient, typically under 45, comes in with low back pain that has lasted for more than 3 months, ask this key question: is your pain better with activity and worse with rest? If they say yes, and they mention significant morning stiffness that lasts over 30 minutes, your suspicion for AS should go way up. Don't just dismiss it as simple back strain. Order an X-ray of the sacroiliac joints and a C-reactive protein or ESR to look for inflammation. Catching as early can dramatically change the long-term outcome for your patient. Let's talk about a super common issue, carpal tunnel syndrome. This is what happens when the median nerve, which runs from your forearm into the palm of your hand, gets squeezed or compressed at the wrist. This nerve controls sensation in the palm side of your thumb and first 3 fingers, and it also controls some small muscles in the hand. The carpal tunnel itself is a narrow passageway on the palm side of your wrist, made of bones and ligaments. When there's swelling in this tunnel from inflammation or repetitive motions, it puts pressure on that median nerve, and that's when the trouble starts. The hallmark symptoms are pain, numbness, and tingling, primarily in the thumb, index, middle, and half of the ring finger. Patients will often describe their hands falling asleep. The symptoms are frequently worse at night and can be so intense that they wake the person up. They might try to shake out their hand to get relief. As the condition progresses, they might experience weakness in the hand, difficulty with fine motor tasks like buttoning a shirt, or even start dropping things. The pain can sometimes radiate up the arm, which can be a confusing factor for diagnosis. Treatment for carpal tunnel syndrome starts with the simple stuff first. We advise patients to modify their activities to reduce stress on the wrist. Wearing a wrist splint, especially at night, is incredibly effective. The splint keeps the wrist in a neutral position, which opens up the carpal tunnel and takes pressure off the nerve while they sleep. Over-the-counter pain relievers like NSAIDs can help with the discomfort. If these conservative measures don't work after a few weeks, corticosteroid injections directly into the carpal tunnel can provide significant, though sometimes temporary, relief by reducing the inflammation and swelling. For severe or persistent cases, surgery to release the carpal ligament is the definitive treatment. For your clinical pearl, here are 2 simple physical exam tests you can do in the clinic: Phelan's test and Tinel's sign. For Phelan's test, have the patient flex their wrists by pressing the backs of their hands together for 60 seconds. If this reproduces their numbness and tingling, it's a positive test. For Tinel's sign, you lightly tap over the median nerve at the wrist. A positive sign is when this tapping sends a little electric shock or tingling sensation into the fingers. If one or both of these are positive, your confidence in a carpal tunnel syndrome diagnosis should be very high. Osteoarthritis, or OA, is by far the most common type of arthritis you will see in your practice. Think of it as the wear and tear arthritis. It happens when the protective cartilage that cushions the ends of your bones wears down over time. Cartilage is a firm, slippery tissue that allows joints to move almost without friction. In OA, this smooth surface becomes rough and eventually wears away completely. When the cartilage is gone, you're left with bone rubbing on bone, which is what causes the pain, swelling, and loss of motion. It most commonly affects the hands, knees, hips, and spine. The symptoms of OA develop slowly and worsen over many years. The main complaint is joint pain that gets worse with activity and better with rest. This is the opposite of the inflammatory arthritis we talked about with ACE. Patients will also report joint stiffness, which is most noticeable in the morning or after being inactive, but it usually doesn't last very long, typically less than 30 minutes. You might hear or feel a grating sensation, called crepitus, when the joint is used. Bony spurs, or osteophytes, can form around the affected joint, which you might see as hard lumps, especially on the finger joints. There is no cure for osteoarthritis, so treatment focuses on relieving symptoms and improving function. The foundation of OA management is non-pharmacological. This includes patient education, weight loss if the patient is overweight. This is huge for knees and hips, and physical therapy to strengthen the muscles around the joint. Low-impact exercises like swimming or cycling are fantastic. For pain relief, we often start with acetaminophen, although its effectiveness is debated. NSAIDs, both oral and topical, like diclofenac gel, are very effective for pain and some inflammation. For more severe pain, intra-articular corticosteroid or hyaluronic acid injections can be used. Ultimately, for end-stage OA, joint replacement surgery is an option. Here is a practical clinical pearl to help you distinguish OA from other types of arthritis, especially rheumatoid arthritis. In OA, the joint involvement is often asymmetrical, meaning it might affect one knee but not the other. Also, look at the hands. OA typically affects the distal interphalangeal joints, the joints closest to the fingertips, which causes little bony nodules called Heberden's nodes. It also affects the proximal interphalangeal joints, causing Bouchard's nodes. Rheumatoid arthritis, on the other hand, almost never affects the distal interphalangeal joints. Seeing those Heberden's nodes is a strong clue you're dealing with OA. Gout is another type of inflammatory arthritis, But it's not caused by the immune system attacking itself. Instead, it's a metabolic problem. Gout is caused by hyperuricemia, which is a fancy way of saying there's too much uric acid in the blood. Uric acid is a normal waste product that's formed when the body breaks down purines, substances found in many foods. Usually, your kidneys filter out uric acid and you get rid of it in your urine. But if your body produces too much uric acid or your kidneys don't excrete enough, it can build up. When the levels get too high, the uric acid can form sharp, needle-like crystals in a joint, and that's what triggers a gout attack. A gout attack is, honestly, one of the most painful things a person can experience. It comes on suddenly, often at night, with excruciating pain, swelling, redness, and intense tenderness in a single joint. The classic location for a first gout attack is the big toe, a condition called podagra. Over half of first attacks happen here. The joint becomes so sensitive that even the weight of a bedsheet can be unbearable. Other joints that can be affected include the ankles, knees, wrists, and elbows. The attack usually peaks within 12 to 24 hours and will slowly resolve over a few days to weeks, even without treatment. Treating an acute gout attack is all about fast and effective pain relief. The top choices are NSAIDs at prescription strength, like indomethacin or naproxen. Another great option is colchicine, which works best if started within the first 24 hours of an attack. For patients who can't take NSAIDs or colchicine, oral or injected corticosteroids are very effective at calming the inflammation. The key is to hit the inflammation hard and fast. Once the acute attack is over, we shift our focus to long-term prevention. This involves lifestyle changes like limiting high-purine foods, think red meat and certain seafoods, and alcohol, especially beer. Your clinical pearl for gout is about diagnosis and long-term management. The definitive way to diagnose gout is to perform an arthrocentesis, drawing fluid from the affected joint and looking for those needle-shaped urate crystals under a microscope. This is the gold standard. For long-term prevention in patients with recurrent attacks, we use medications that lower uric acid levels, like allopurinol or febuxostat. Here's the critical tip. Never start a uric acid-lowering medication like allopurinol during an acute gout attack. It can actually make the current flare worse by mobilizing uric acid stores. You must wait until the acute attack has completely resolved before starting preventative therapy. Low back pain is not so much a specific disease as it is a symptom, and honestly, it's one of the most common reasons people see a primary care provider. The vast majority of cases, we're talking over 90%, are what we call mechanical or non-specific low back pain. This usually means a lumbar strain or sprain, which is basically an injury to the muscles or ligaments that support the spine. This kind of thing can happen from lifting something heavy, a sudden awkward movement, or even just poor posture over time. While it's incredibly painful and disruptive, the good news is that it's almost always self-limiting, meaning it gets better on its own with time. The symptoms of a typical lumbar strain are pain and stiffness in the lower back. The pain is often described as aching or dull, and it can be localized or spread across the back. It typically gets worse with movement, like bending or lifting, and feels better with rest. The patient usually won't have any red flag symptoms. Red flags are the warning signs you must screen for, which could indicate a more serious underlying cause. These include things like fever, unexplained weight loss, pain that is worse at night or at rest, bowel or bladder incontinence, or neurological symptoms like weakness or numbness radiating down the leg. For uncomplicated, acute low back pain, the treatment mantra is to stay active. Old advice used to be strict bed rest, but we now know that's one of the worst things you can do. We encourage patients to continue their ordinary activities as much as they can tolerate. Heat or ice packs can provide some symptomatic relief. For medication, we can use short-term NSAIDs or acetaminophen. Muscle relaxants can be helpful, especially if there's significant muscle spasm, but they can cause drowsiness. The most important intervention is patient education. Reassure them that this is very common, it's not serious, and it will get better. The clinical pearl here is all about identifying those red flags. When a patient presents with low back pain, your first job is to rule out the scary stuff. Always ask about bowel or bladder changes, like incontinence or retention, which could signal cauda equina syndrome, and that's a surgical emergency. Ask about numbness in the saddle area, meaning the groin and inner thighs. Ask about a history of cancer, fever, or IV drug use. If a patient has sciatica, pain that radiates down the leg below the knee, often in a specific nerve pattern, that suggests nerve root compression, possibly from a herniated disc. If there are no red flags, you can confidently manage the patient conservatively without ordering expensive imaging like an MRI in the initial phase. Osteoporosis is a disease that makes bones weak and brittle, so brittle that a fall or even mild stresses like bending over or coughing can cause a fracture. It's often called a silent disease because, honestly, you typically don't have any symptoms until you break a bone. It happens when the creation of new bone doesn't keep up with the removal of old bone. Our bodies are constantly remodeling bone tissue, but with osteoporosis, bone mass is lost, and the internal structure of the bone deteriorates. This makes the bone porous and fragile, hence the name osteo for bone and porosis for porous. As I mentioned, osteoporosis itself has no symptoms. The first sign is often a painful fracture. The most common fractures associated with osteoporosis occur in the hip, spine, meaning the vertebrae, and wrist. A vertebral fracture can lead to a loss of height over time, or a stooped posture known as a dowager's hump. These fractures can happen without a significant fall. Sometimes the vertebrae just compress under the normal weight of the body. A hip fracture in particular is a devastating event for an older adult and is associated with significant morbidity and mortality. This is why screening and prevention are so incredibly important. Treatment and prevention are key. We encourage all patients to get enough calcium and vitamin D, which are the building blocks for strong bones. Weight-bearing exercise like walking, jogging, and strength training is also crucial because it stimulates the cells that build bone. For patients diagnosed with osteoporosis, especially those who have already had a fracture, we use medications. The first-line treatment is usually a class of drugs called bisphosphonates, such as alendronate, also known as Fosamax, or risdronate, which is Actonel. These drugs work by slowing down the cells that break down bone, which helps to preserve bone density. Your clinical pearl for osteoporosis revolves around screening. We need to catch this before a fracture happens. The U.S. Preventive Services Task Force recommends bone density screening using a DEXA scan for all women aged 65 and older. They also recommend screening for younger postmenopausal women who have an increased risk. A great tool to assess this risk is the FRAX score calculator. You can plug in a patient's risk factors, like age, smoking history, family history of fracture, and it will calculate their 10-year probability of having a major osteoporotic fracture. This can help you decide which younger women need a DEXA scan. Rheumatoid arthritis, or RA, and systemic lupus erythematosus, or SLE, are both chronic autoimmune diseases. This means the body's immune system, which is supposed to protect you from invaders like bacteria and viruses, mistakenly attacks its own healthy tissues. In RA, the immune system primarily targets the synovium, which is the lining of the membranes that surround your joints. In SLE, the attack is more widespread and can affect almost any part of the body, including the joints, skin, kidneys, blood cells, brain, heart, and lungs. Both conditions are more common in women and can be incredibly complex to manage. With RA, the main symptoms are joint pain, swelling, warmth, and stiffness. A key feature is that the joint involvement is typically symmetrical, meaning if one wrist is affected, the other one probably is too. The stiffness is most severe in the morning and can last for more than an hour. RA commonly affects the small joints of the hands and feet first, like the knuckles. Those are the MCP joints, and the middle finger joints, or PIP joints. Over time, this chronic inflammation can cause severe joint damage and deformity. Patients also often experience systemic symptoms like fatigue, fever, and weight loss. With SLE, the symptoms are famously variable and can mimic many other illnesses, which is why it's sometimes called the great imitator. A classic sign is a butterfly-shaped rash across the cheeks and nose called a malar rash. Patients often experience profound fatigue, fever, and joint pain similar to RA. However, lupus can also cause photosensitivity, which is a skin reaction to sunlight, mouth sores, hair loss, and more serious complications like kidney inflammation, lupus nephritis, or inflammation of the lining of the heart and lungs, known as pericarditis and pleuritis. The symptoms tend to occur in flares with periods of remission in between. Treatment for both RA and SLE is aimed at controlling the overactive immune response to reduce inflammation, relieve symptoms, and prevent long-term organ damage. For RA, we use disease-modifying anti-rheumatic drugs, or DMARDs. The cornerstone DMARD is methotrexate. For more severe cases, we add biologic agents like the TNF inhibitors we discussed for AS. For SLE, treatment depends on which organs are involved. Mild cases might be managed with NSAIDs and an anti-malarial drug called hydroxychloroquine. More severe flares, especially those involving the kidneys or central nervous system, require high-dose corticosteroids and other immunosuppressants like mycophenolate or cyclophosphamide. Your clinical pearl is to remember the key lab tests that help point you toward these diagnoses. For RA, you'll want to order a rheumatoid factor and an anti-CCP, which stands for anti-cyclic citrullinated peptide antibody test. The anti-CCP is much more specific for RA. For SLE, the key screening test is the anti-nuclear antibody, or ANA. If the ANA is negative, it's very unlikely the patient has lupus. If it's positive, you would then order more specific antibodies like anti-dsDNA and anti-Smith antibodies, which are highly specific for SLE. These lab tests, combined with the clinical picture, are essential for making the correct diagnosis. We've covered a lot of ground, from fused spines and pinched nerves to crystal attacks and silent bone thieves. As you prepare for your FNP exam, the musculoskeletal system can feel overwhelming, but it really doesn't have to. The key is to focus on the patterns. Don't just memorize isolated facts. Understand the why behind each condition. Why does osteoarthritis hurt more with activity? Because you're rubbing worn-out cartilage. Why does rheumatoid arthritis hurt more with rest? It's because inflammatory fluids and cells accumulate in the joint when it's not moving. Thinking this way turns memorization into true clinical reasoning. Your success on the exam, and more importantly in your future practice, will hinge on your ability to differentiate these conditions. Create a simple mental chart. For back pain, is it a young man with inflammatory symptoms? Think AS. Or a middle-aged person with a lifting injury? Think strain. For joint pain, is it a single hot, swollen joint? Think gout or septic arthritis. Or multiple symmetrical small joints with prolonged morning stiffness? Think RA. Or is it an older adult with asymmetrical large joint pain that's worse at the end of the day? Think OA. These simple branching questions will guide you to the right answer. Remember the key takeaways for each condition. As young men, inflammatory back pain, better with activity. Carpal tunnel median nerve, Phelan's and Tinel's tests. Osteoarthritis, wear and tear, asymmetrical. Heberden's nodes on dip joints. Gout, uric acid crystals, podagra, don't start allopurinol during an acute attack. Low back pain, rule out red flags first. Osteoporosis, silent disease, DEXA screening for women 65 and older. RA symmetrical, morning stiffness greater than 1 hour, anti-CCP is specific. Lupus multisystem, malar rash, ANA is the screening test. This is your high-yield cheat sheet. Finally, as you head into the exam, be confident. You have put in the work. When you see an MSK question, take a deep breath. Read the stem carefully and pull out the key information. The patient's age, gender, the timing of their pain, the specific joints involved, and any associated symptoms. Use the pearls we've discussed to build your case for one diagnosis over another. You are building the foundation for an incredible career where you will help people move better, feel better, and live fuller lives. You've got this. Now go and show them what you know.